For most part, in our center, and I think in most of the United States and in environments when this is approved, we use lenalidomide as a maintenance regimen post-transplant. Two major studies and meta-analysis showed progression-free survival superiority. In one of two studies, overall survival. In two of three studies, I should correct myself, and meta-analysis show overall survival. There was such a dramatic difference in progression-free survival and overall survival that to many of us this is strategy to beat and to improve. I have to say that even from these meetings we are hearing how important it is to use lenalidomide even after very good regimens. This morning there was a presentation from Great Britain of one of the British studies in which one of the arms was KCRD, which is carfilzomib, cytoxan, lenalidomide dex, and the results are outstanding for a KCRD. Very much powerful regimen, bringing very similar to RVD and DARA response rate at the end of induction. Progression-free survival in patients who had not received after induction anything except transplant was maybe shorter than I would have expected, but there was randomization to lenalidomide maintenance versus nothing, and there was about 20% improvement of progression-free survival after adding lenalidomide, proving that even after as excellent induction as KCRD plus transplant, lenalidomide maintenance improve outcome. So that would be my short, maybe to the point reasoning why we are using lenalidomide. At this meeting, and in some prior meetings, there was a number of alternatives presented to potentially go different route. There was a study in the past which showed equivalency of bortezomib every 2 weeks to thalidomide, which was maybe imperfect, really adopted as standard of care. At this meeting there was a study of Ninlaro, or I should say ixazomib, which was compared to placebo, which was presented at yesterday's oral session, which was positive to some extent as expected. The margin of improvement in the range of about 6 months compared to placebo is something which we need to wait and see how much it will impact our choices for maintenance. I suspect that indirect comparisons are clear in favor of lenalidomide. That those who are in the camp of believers in lenalidomide will probably not be persuaded by this study to change to Ninlaro, to ixazomib, but there will be potentially some movement towards adding ixazomib to lenalidomide. There was a study by Dr. Veach presented at this meeting which shows that consolidation with ixazomib Lendex improves depth of response post-transplant, so there is some rationale for this type of strategy. I have to say that this question is important for me because this is area of our very important research investigation based on a number of prior results and rationale that post-transplant treatment is important, as I indicated, for improving outcome. We argue that single agent may be not enough for young patients who are transplant candidates, for the most part young, and these patients receive on average 4 to 6 cycles of induction, transplant, and then just single agent. When we learned the extended treatment with triplets is better than stopping triplets too early. So we are stopping intensive treatment for these patients after a relatively short course. Based on this rationale, we are conducting 2 randomized trials, which University of Chicago leads. The one is with ixazomib Lendex for patients who have residual disease at least MRD positive, and patients are randomized to ixazomib Lendex versus Len, continuation of lenalidomide, Revlimid, for 1 year, and primary endpoint is to see whether we convert at higher rate patients to MRD negativity after 1 year of treatment with triplet versus lenalidomide maintenance standard of care. Another study, which is based on our preliminary results from KRD transplant followed by KRD extended treatment, is randomization, all comers, regardless of their response. We do it in collaboration with Polish Myeloma Consortium, which is the primary enroller into this study, which will enroll about 200 patients. We anticipate to finish enrollment early spring. And that study randomizes patients to KRD, extended treatment post-transplant based on our KRD transplant KRD results, and lenalidomide maintenance. And we believe that this is one of those important evaluations in progress which may potentially change, depending on the results, future treatment of post-transplant myeloma. I would add a caution that the reason why we do those studies, even if there is anticipation that triplets will be better than single agents, that treatment patient post-transplant with anything more intensive than single agent has potential for improving depth of response, but also has high likelihood of increasing toxicities, including frequent infections, lowering the counts, and further worsening of immunocompromised status. So those randomizations and randomized evaluation of these strategies are important because they will look at complexity of outcome, not only at specific efficacy, but also on tolerability of these regimens.